Hello, everyone, and welcome to today's webinar, A Trauma-Informed, Equity-Focused Approach to Suicide Prevention in Teens and Young Adults, Looking Beyond the Individual, led by Dr. Angela Tuno, who is a licensed clinical psychologist and assistant professor of psychiatry and behavioral sciences at the Duke University School of Medicine. My name is Anna Kate Bogarts, and I'll be your webinar moderator for today. Before we get started, I wanted to let you know a little bit more about the RBEST program and do some basic housekeeping announcements. Arkansas Building Effective Services for Trauma, or RBEST, is a state-funded program at the UAMS Psychiatric Research Institute, and our aim is to improve mental health services for children and families who have experienced trauma. We work closely with multiple partners to build a more trauma-informed state, and we're probably best known for providing training to mental health professionals on treatments that are effective with helping children and families recover from trauma. So that's a little bit about us. I'm sure a lot of you know already, but for those who don't, and some quick housekeeping announcements. We encourage you to ask questions. You can do that using the question feature or the question box, which should be kind of on your panel there with GoToWebinar. You can type that in throughout the presentation, and we'll have a time at the end to address some questions, but also please use this for some real-time engagement. Dr. Tuno might be asking some questions throughout, so if you are able to participate by typing in some answers, you can also use this question box like you would a chat feature like in Zoom. So feel free to do that as well. If you're interested in earning a CEU, just make sure that you stick around to the very end, and I will give you a code that you can use to type in to get your CEU through a Google form, and I will email that out to everybody after the webinar. We are recording this webinar, which we'll upload to the RBEST YouTube channel. We have other previously recorded webinars there too, so make sure you check those out. And finally, don't forget to check out the RBEST Facebook page and like us. That's where we post upcoming training opportunities, webinars, and other resources. So make sure you go and check us out over there. So that is all the housekeeping I have. I'm very excited to turn this over to Dr. Tuno, who is presenting on this topic for us today. So, all yours.
Thank you. Thank you, Anna Kate. Appreciate it. Welcome, everyone. I haven't been on, I'm looking at the name of a go-to meeting in a really long time. So it's like talking into a void. I was talking about that before because I like to see your faces. And I know it's noon in Arkansas. It's 1 o'clock here. So if it is noon, I hope you all can at least sit back, relax, enjoy some lunch during our time together today. I wonder if it's okay if we can just check with the question feature. If you all could just say hi or something like that so I can see if I can see what you all put in the chat or the question feature, if that makes sense. And it looks like there's an ability to send privately and send to all. I can just test it out for a second.
Are you able to see those come in, Dr. Tuno? Okay, so I'll be the one reading out then, because it looks like I'm the one that has control of this, and I'll see if I can give you control. But in the meantime, lots of people are writing in. Hello from mostly from all over Arkansas, somebody from Tuscaloosa, Alabama, Memphis, Tennessee.
Oh, okay.
We have a good group chiming in here, so.
We got a range. That's wonderful. Well, welcome everyone. Please use the question feature. Anna Kate, I'm gonna put you on the spot and have you be my person to read it out, if that's okay.
Yeah, no problem.
All right. I'm going to try to move forward with our slides. I have remote control, but I am not. There we go. There we go. All right, so welcome everyone. My name is Dr. Angela Tuno. I work over at Duke University School of Medicine. I'm a licensed psychologist, assistant professor there. I wear many different hats, clinical being one of them, do some research and a lot of community-based, community-led, trauma-informed work. And I just wanted to give some acknowledgments to my colleagues at the Duke University School of Medicine, the ASAP Center, which is a formerly funded center by the NCTSN. And I would usually say like, hey, have you heard of the NCTSN? If you have, great. If you haven't, go check it out. It's nctsn.org. And it is a national network of different centers across the US. I think we're up to 148 at the moment of currently funded, but many more than that who are formally funded that focus on trauma-informed care for youth communities and families. And Duke happens to be one of the coordinating centers for the NCTSN. So I get to learn from and work with colleagues across the nation. There's lots of resources there for you to use, so feel free to go and check it out. And the ASAP Center, which is a really, like there's a very long acronym related to it, but it's the UCLA Duke Trauma Informed and Adolescent Suicide, Self-Harm, and Substance Use Treatment and Prevention Center. So thank you all for having me today. Before we get started, I would like to just have a mindful moment and lean into the fact that the topic that we're covering today can be difficult. And we all come with our own experience and expertise, and just acknowledging that in this space today. I want you to go ahead, and you already tried it out, pull up your question feature to participate. I want you to monitor your own distress level during our time together, and whatever you need in this moment. If you need to get up and walk around, go get some lunch, just sitting back, putting your phone away. I just put mine away. I think I closed my email, so I'm hoping you won't hear the email dinging throughout our time. And we also have lots of virtual meetings these days, so take a break from looking at the screen. You can listen, participate how you will. And we already oriented to date and time. Just so glad you all could be here today. Okay. Some objectives, what I'd like to do in 52 minutes is look at the latest trends and scope of the problem. There's a lot of data coming out and very frequently. So I can say at this time, this is where the latest trends are, knowing that we are learning more every single day. We'll talk a little bit about risk factors and relation to trauma exposure, suicide, and the relation to trauma exposure. I want to take us and look beyond the individual as well. A lot of times when we talk about suicide prevention and intervention, it's at that individual level, how to collaborate on a safety plan, which is all very important. And I'm going to ask for us too to scope out and think about trauma-informed suicide prevention more broadly. And you'll hear more about that in a second. And then I'll have you zoom back in on the individual lens to talk a bit more about trauma-informed suicide prevention and intervention. Okay. Getting started with some engagement, because I'd like to hear just a little bit about what you all think of when you think of the trauma-informed piece, of suicide prevention for teens. So in the question box, and Anna-Kate, get ready for this, in the question box, or you can unmute, maybe, I don't know if you can, provide a few words reflecting your answer to the following question. What are some words or thoughts that come to mind when thinking about trauma-informed suicide prevention for teens? It can be one word, can be a couple words, your experiences.
Complex, necessary, all about self-worth, knowing the risk factors, fear of missing the signs, helping risk with higher incidences, at risk for higher incidents of suicide, the need to be age appropriate, getting on their level, similarly, safety, awareness of how trauma history makes one more at risk.
Yeah.
compassion, complex PTSD, being alert, the importance of social connection, building a support system, developmentally appropriate with safety, ability to connect with someone with a trauma history, patience and rapport, the family environment.
These are all really good. I love having these engagement pieces because I like to be able to talk with you all, but I also love being able to learn with you all. There's a lot of collective wisdom in this space, and some things that I'm hearing about, like self-worth, the importance of connection, how trauma is related to suicidal thoughts and behaviors. And then I heard a couple times, Anna Kate, you say the developmental appropriateness of the work that we do, keeping that in mind when working with adolescents, and the family context as well. And we'll talk about all of those things. So I'm glad you all brought it up. Thank you for participating. Okay, starting off, and I'll move quickly through these because it's really focusing on the current statistics. Going from 2019 to 2020, I did take a look to see if the 2021 data was out on the CDC WISCAR's platform, and I didn't see it quite yet. Oops, I'm going to. Oh, goodness. Anna Kate, can you help me go backwards? I don't know if I can. There we go. Thank you. 220, that right there. Thank you very much. All right. So looking at the 2019 data, and you can zoom in here real quick, is that we know, and for the 4 years previous to 2019, we know that suicide was the second leading cause of death for youth. 10 to 14 and 15 to 24-year-olds, and even beyond that, as you can see, from 25 to 34-year-olds. And that has remained pretty steady over the past 4 years prior to 2019. The 10 to 14-year-olds, it can ebb and flow between second and third leading cause of death. We know that there's higher rates in suicide death in males compared to females, and that from 2007 to 2017, we saw an increase, a 56% increase in suicide rates for young adults and youth between the ages of 10 to 24. The most common methods that we know of for the younger age range, 10 to 14-year-olds, is suffocation and strangulation. And then for 15 and teenagers and above, we know that firearms are the most common methods for suicide death. So just grounding ourselves in what the trends have looked like up to 2019. And I have to really look at okay, I think I can move it forward. And now looking at 2020. So as you can see, in the green is the suicide deaths from 2020, and having us look at the 10 to 14-year-olds and 15 to 24-year-olds. I'm going to use my mouse here. So again, 10 to 14-year-olds, second leading cause of death. For 15 to 24-year-olds, it moved to the third leading cause of death, which can be a bit confusing if you look back on 2019 at the actual numbers. There was actually an increase. So from 15 to 24-year-olds, it went from 5,954 to, in 2020, 6,062. So it can be confusing because it looks like it went down, but what actually happened was the homicide-related deaths went up. So that's where you see that difference. Still higher rates in males compared to females. The most common methods are exactly the same. For younger youth, it's suffocation and strangulation. For teenagers and older youth, it's firearms, and that goes from that age and beyond. And I want you to think about that when you're thinking about working with youth, when you're thinking about lethal means restriction or safe storage of potential lethal means, and what you can be thinking about in terms of safety planning. One of the caveats that I like to say when I'm looking at stats is the message on rates can sometimes be really confusing, and I get confused by it all the time. I have a lot of colleagues that will sit there and just pour over some of the information that's being sent out, and it's happening really quickly, so it's hard to keep on top of it. And how important it is to disaggregate the data and make sure we're looking for disparities and disproportionalities that exist. That sometimes you'll see people will stop at it's the second leading cause, third leading cause of death, and really there's so much more. There's so much more for us to learn when we actually break apart data based on different intersecting identities, gender, race, ethnicity, sexual orientation, gender identity, and look at the suicide rates and the suicidal thoughts and behavior rates based on those identities. One way to do that through age. I know this is super small for you all, but you're going to get a copy of the slides as well. I went ahead, there's this great platform called WISCARS, WISQARS from the CDC. Publicly accessible data, you can go in and plot the data and look at it in different ways, which is wonderful that you're able to disaggregate it like that because it's so important. But for the 10 to 19-year-olds, I went ahead and plotted 2000 to 2020. You can look at how the trends, and this is death rate per 100,000 or crude rate over the course of those years. So you'll see that increase that we talked about around 2017. And there was a slight decrease. And then in 2020, we're learning more about what those trends are. Then let's also break it out by race and ethnicity. And I broke it out into age ranges. So these are for 10 to 14-year-olds. And I want to take a pause here because there is a clear disproportionality here as well. And as you can see, these two are white, non-Hispanic, white, Hispanic, black, non-Hispanic, black, Hispanic, American Indian, Alaska Native, non-Hispanic, American Indian, Alaska Native, Hispanic, Asian Pacific Islander, and Asian Pacific Islander here. So I want you to take a look and see what you notice. And I usually have you all put it in the chat, but for time's sake, I'm not going to. But when we're thinking from our trauma-informed lens, from a broader way, and think about structural inequities, historical and ongoing trauma and oppression, and how that relates to the rates that we're seeing for American Indian, and for other groups you'll hear in a second, of how those things are related. When we're thinking about our trauma-informed lens and thinking about those systems of oppression, access to resources, systemic structural racism and historical racism and trauma, that we need to look at that as a contributing factor as well. Same thing for the 15 to 19-year-olds. You can see where the disparities and disproportionalities exist. Okay. I also wanted to lift up this wonderful resource that I think is really important for all of us to read, and as the new data is coming out, making sure we're asking those questions and asking for the data to be broken up in these ways. This came out, and I'm trying to remember the exact date that it came out, but it was a while ago, but the growing crisis of Black youth suicide in America. And I encourage you all to read it and dive into it more, but a little highlight is that from 2007 to 2017, for Black youth under the age of 13, the rate almost doubled from 2.55 to 4.82. And especially for younger youth, those 5 to 11-year-olds are more likely to die by suicide compared to their white peers. So it's a trend that they're looking at. It's not only in comparison to other groups, but it's also looking at the growth rate in which this rate is growing, the linear growth rate. So I went ahead and plotted that in WISCARS to take a look at that trend that they're seeing and describing. And you can see from 2010, especially to 2020, that you can look at, and this is for Black youth age 10 to 19, the growing trend of death by suicide, and broke it up from Black non-Hispanic, Black Hispanic, and Black unknown was the term that they used. But looking at that linear increase and thinking about what could be related to this from that broader lens, and continuing to ask those questions. I would have more in the chat, but I'm going to move forward because we can talk more about that in a second. Okay. I'm sure a lot of you are familiar with the YRBSS. It's I'm going to make sure I get this right, the Youth Risk Behavior Surveillance System. And it contains a survey that all high school students would take from 9th to 12th graders. So it's a nationally representative sample of public and private schools. And I don't know if you all remember taking this survey. I remember taking it as a high school student. It happens every 2 years. And the latest data we have is 2019. I did just find out that there's new data coming out in the spring of 2023. So I'm really interested in that data when it does come out. And it takes a look at different health risk behaviors from drug use, smoking, wearing your seatbelt, bullying behaviors, lots of different things. One of them is suicidal thoughts and behaviors. And I find this really important data because it gives us some insight. Of course, there's flaws to it because how comfortable people are in reporting it and the anonymity of it, how safe they feel. But it does give us some information about suicidal thoughts, plans, attempts as well. So what are our high school students saying in 2019? And it's over the past year. So from 2018 to that point in 2019, over the past year, almost 19% of our high school students who took this survey seriously considered attempting. I broke it up by female and male, and noting that this is limited by binary gender identity, but when we break it up to female and male, you can see there's higher rates in female that considered than male. Then when we go a little bit further in risk, how many planned how they would attempt? About 16% of our high school students. And then if we go a little further in risk, how many had an actual attempt? At least once. We get about 9%. And that trend, that data has increased. There's been a linear increase, a steep increase from 2009 to 2019. And I want to also highlight that females are more likely to have thoughts and non-lethal attempts. Males are more likely to die by suicide or have more lethal attempts. And as we're thinking about systems, communities, and taking it broader than the individual, I want you to think about contributing factors to that. What might contribute to females having more likely to have thoughts and non-lethal attempts, and males to be more likely to die by suicide? The YRBSS, there's lots of ways to break it up. This is one way that they did it, and I put their categories in quotes because that's how it was in the article. But when you can also go into a system, I put a link in the slide before, where you can break up the data yourself and take a look at different disproportionalities that exist. But when we look at making a suicide plan and then those who attempted suicide, you can see different, the categories they used were white, Black, and Hispanic. And making a suicide plan, you can see it's a little even, there's not too much different, but when we go into attempting suicide, you'll see a difference here, with white at about 8%, and then you can see for Black and Hispanic about the same. Then I also wanted to break it out by sexual orientation. Again, these are the terms that they used in their categories in this article. So they broke it out by heterosexual, they used the term LGB, and then they had another category called not sure. You can also see the disproportionalities here. And in fact, we do know that compared to their heterosexual cisgender peers, youth who identify as LGBTQIA+ are 3 times more likely to attempt suicide in comparison. So when we're thinking of risk as well, and thinking of resourcing and resources and contributing societal factors, I want you to keep that in mind as we go forward these statistics. So let's talk about risk factors and the relation to trauma. We'll do some engagement here. Anna-Kate, if you're ready. I want you to think about what are some risk factors after going over those stats, and then over the past, I don't know, since 2020, what are some risk factors associated with the impact over the past few years for youth suicidal thoughts and behavior? And I like to say it's more of a syndemic than a pandemic, because we had multiple pandemics over the course of the past few years, right? I mean, we had COVID, We had continued systemic and structural racism that goes beyond the past couple years. And we had economic insecurity, we had civil unrest, we had political unrest, we had mental health crises. So that really thinking about the context of the last few years, what are some risk factors you think are there for youth?
So far, minority status, isolation, lack of support systems, the pandemic itself, trauma, previous attempts, social withdrawal, home life, cyberbullying, lack of social interactions, not feeling connected, poor support from peers, poverty, drug and alcohol prevalence, educational struggles, feeling like a burden.
I'm just jotting this stuff down so I'm tracking it. Yeah. No, this is really good. So that isolation piece, absolutely. And going along with educational burden too, of all of a sudden, you know, people who had access at least had to do remote school and they were isolated. Also with trauma, if they were in an unsafe living situation of being there as well, and isolated from school or from peers, previous attempts, social withdrawal, cyberbullying, that window is always open. That's something I think about a lot is for teenagers, is that you don't ever really leave school behind. There's always a window to your peers. Feeling like a burden, past attempts. You all are doing the work for me, so this is good. Let me see if I can move forward. Yeah. I'll sometimes use these categories as well, and you all gave great examples of these. Sometimes it's precipitants or things that happen right before that are extremely stressful. It could be an interpersonal conflict, a breakup with a partner, a romantic partner, a fight in the family, a loss and grief. And when I think of grief, especially in the context of the past couple years, I think of it doesn't have to just be a person. It can be a milestone or something we're looking forward to. There were some folks who missed graduation, proms, having that sort of sense of loss. I also want to put the caveat here that we know that there's no single factor that predicts suicide. Risk factors do exist, but we need to be very careful about saying that we don't know a single risk factor. We do, or a single factor that predicts 100%, but we do know these risk factors do exist. Then we can talk about demographic and specific populations. You all already talked about that. Minority status, age, gender, race, ethnicity. We saw a little bit of that. Access to mental health care. There's some new data that just came out that looked at rates of between 2015 and 2016 and access to mental health resources, and looked at the relation between that and suicidal thoughts and behaviors. Don't quote me on that about suicidal thoughts, behaviors. It could be death by suicide, but what they saw after controlling for demographic characteristics, they saw that access to care, lack of access to care was directly related to risk. So that's something to keep in mind too. I also want to put a plug out there for you mental health professionals as well, is there's a capacity issue, right? Of how do we think about suicide prevention, of course, mental health, but in also other broad ways as well. Structural and systemic inequities, social, you all talked about this, right? Feeling isolated, feeling alone, economic hardships of families during this time and beyond, unsafe or abusive living situations. So in that social distancing period, some folks were in homes that may have been unsafe. Historical, someone said that too, a history of suicidal behavior that can be within yourself, that can be within your family. Experiences of trauma is directly related. Mental health conditions, especially untreated mental health conditions, access to substances or substance use difficulties, And then access to lethal means too. So firearms, medications. I want you to continue thinking about others as well as we continue today. Now, the relation to trauma, I don't think this will be a surprise to anyone in this space together, that we know that traumatic stress or exposure to trauma and the symptoms related to it is associated with increased risk for suicidal thoughts, suicidal attempts, and self-harm with and without suicide intent. And I have some citations here at the bottom, but these are a result of meta-analyses where folks went in and looked at the data over the years that compared trauma and suicide and later suicidal thoughts and behaviors, and took a look especially at child maltreatment, and found that all types of child maltreatment, sexual, emotional, physical, and neglect, are related to later suicidal thoughts and behaviors. The strongest links that they've seen was across childhood sexual and emotional abuse, although what they did find is that there is a dosage effect across all types. So the more potentially traumatic events someone experiences, the greater their risk is for the frequency of suicidal thoughts, behavior, and self-harm. And that's been shown time and time again, is that there is a relation between trauma, especially that dosage effect, and later risk for self-harm, suicidal thoughts and behaviors. And I want you to think about why that is. There's theories out there that exist, and there's a lot of collective wisdom in this room of how those two things are related. And you don't have to put it in the question box, but I want you to think about what contributes to that. Okay, we're halfway in. I hope you all are with me. I want to go ahead and scope out, looking beyond the individual. We've talked a lot about statistics of the death rate across the years, of suicide risk, thoughts and behaviors of high school students. We've talked about individual risk factors and even beyond risk factors. And I want us to think a little bit beyond the individual when we're talking about trauma-informed suicide prevention. It's important that we acknowledge that we live and participate in a society of structural racism and systems of oppression with unequal distributions of power and access to resources. And you can see on the right, this is actually from the CDC, but it's a public health framework. It's the ecological model, I think of Brofenbrenner's work of the individual, relationship, community, and society. And I think it's really good for us when we're thinking about intervention, prevention, and postvention, how we acknowledge people don't live in a bubble. They're influenced by their relationships, their community, and the larger society. And all layers are related, and our efforts must reflect that same layered approach. So although individual intervention is so needed, that intervention at the relationship, community, and societal level is also critical. Because, and I'll highlight this last point here that's in blue, a sole focus on the individual experience of trauma and suicidal thoughts and behaviors without a focus on societal factors that maintain contributing factors like systemic oppression is not enough. And it can actually be a distraction from a root cause. And although a needed one, because again, I'm a psychologist, I do a lot of individual work. I also do a lot of more public health, broader work as well. Both are very important. I want to lift up this quote by Prentice Hemphill. I don't know if you all have read this book, You Are Your Best Thing. It's really great. Tarana Burke and Brene Brown collaborated on it. And what Prentice says is, healing this generational trauma requires an end to what continues to traumatize us. On the other side of healing is not a return to what has been, but instead a renewed purpose, deeper relationships, and dignity for the collective. So I want you all to think about that, of not a return to what is, but healing is a renewed purpose, changes, deeper relationships, deeper understanding, and dignity and honoring the collective. Part of that, when we're thinking about broadening our scope, is turning the lens inward first and checking ourselves. It's important to first understand, before working with youth, families, and communities, our own biases. And I find it really important to lean into the fact that we all have biases. We all have that as a part of our socialization and racialization. We have these biases about ourselves, others, and our worldview. And it's important to get curious. Get curious about those prior to showing up with working with youth, families, and communities, especially youth families and communities that have been impacted by trauma and are having experiences of suicidal thoughts and behaviors. Part of that is leading with cultural humility. And there's a lot of definitions of cultural humility out there. I like this one. It's pretty straightforward, although the practice of it is not, it's very complex and it's lifelong. And I like it because it highlights that. It's a lifelong process of two parts. One is self-reflection and self-critique, where you start with an examination of your own beliefs and your own cultural identities, including your biases. Where are my blind spots? Why did I have that sort of like internal experience? Getting curious. So you have that own self-reflection, and then also a commitment to authentically learning about others' cultures. So showing up with the wherewithal, or not the wherewithal, the reflection of yourself while also wanting and desiring to learning about others' cultures. Part of that is acknowledging the implicit bias, of the unconscious bias, attitudes and beliefs that occur outside of our conscious awareness and control. It's those rapid, almost automatic associations that shape and mold our behavior. So I think of this reflexive, those reflexive, rapid, and automatic associations. Part of it is really getting curious and calling it in of when you're having conversation with colleagues, and even consultation on a case or working alongside a family, getting curious about the biases that show up. Those are stereotypes, assumptions, other associations that influence how we see, how we feel, how we quote unquote know, judge, and behave. We all have them. And when we're doing this work with youth and with communities, when we're thinking about prevention, we want to approach with this trauma-informed lens. And I like to think of that as a humility and learning mindset. Some questions that I ask myself when I'm working with youth and communities. What core beliefs about self, others, or the world may be held by youth? And what core beliefs are held by me, too? What is their and your experience of the world? And those include things like experiences of socialization, of our own privilege, oppression, discrimination, racism, and thinking from that intersectional lens of that all identities, they don't exist in silos, they coexist, right? They exist together. We don't want to assume, we want to ask and practice that self-awareness of our own biases. And part of that, you may be thinking, how is this about suicide prevention and intervention? But part of that is a big, big part of understanding what has this experience been like for this youth. That's part of our safety planning process. It's part of understanding community-led work. Getting curious about what experiences, including traumatic, have or may have occurred. How does this relate to their suicidal thoughts and behaviors? On the other side too, which is so important, I think incredibly important, and is an honor to learn, is what protective factors exist. Methods of healing, support systems. How can I incorporate this into the safety plan? You know, I'm thinking about what religious beliefs or affiliations do they have, or what do they do in their community that might bring them joy in times of darkness? What are their cultural practices? What have they learned from their ancestors or from those that came before them about healing and growth, and learning and leaning into that and incorporating that in your treatment plan? I'm looking at the time. I think we got time for this. So thinking from that systems lens, and I've heard this quote a number of times, and I tried to dive in and find who said this quote, and I couldn't find it, so apologies. And if somebody knows who said this, please put it in the question box, because I'd love to know too. That people describe suicide as a public health issue that requires a public health response. I could not agree more. That when we're talking about the individual intervention, it's important, and we also have to think in terms of relationships, community, and societal. Let's go with, when you're looking at that image, let's go with community. So when you think of suicide prevention on a community level, what would that look like to you for youth? And you can put it in the question box. And Anna Kate, if you could help me out again, sorry. Starting with community. What could that look like?
Community healing and support.
Mm-hmm.
Social emotional skills taught in schools.
Yep.
Youth-oriented suicide intervention. Let's see, suicide prevention programs, youth programs, after-school involvement. Creating open spaces to discuss suicide and spread awareness. Educating the community on risk factors, cooperation between the community, different parts of the community.
Mm-hmm. Mm-hmm.
Working to reduce the stigma.
Yep.
Adults and kids' lives. I missed it. It scrolled past me.
Okay.
But I think it was basically like having an adult presence in a kid's lives.
Yeah. These are all really good. Keep them going. I think you all mentioned a number of really good things. Having social and emotional learning in schools as a foundational practice, right? It's how do we talk about mental health? How do we reduce that stigma in a place where youth are, like schools? How do we collaborate with different child and youth facing organizations? So like, you know, like a local YMCA or recreational organizations as well as schools and other community members to make it more of a community concern or community thing to address than just an individual, right? Because we know connection is healing. Somebody said community healing, and I loved that because yes, connection is healing. We know connection is a protective factor against suicide. And I love those examples of ways to connect and come together. We're learning more and more about peer-to-peer intervention and prevention works too, because if you think about adolescents, there's a lot of caveats to that, especially regarding safety, because we want an adult involved for sure. And how can we use their natural, from that developmental lens, their natural tendency to talk to their peers, of course, in a way that's help promotive of mental wellness. If it's an acute risk, we want adults involved, and peers can be a huge resource. Okay. I want you to also think about societal factors as well. We're not going to have time to go into that. I wish we did. But thinking about norms, culture, policies, inequities that exist, how addressing inequity is suicide prevention, addressing trauma is suicide prevention, and keeping that in mind. Okay, I'm going to go back into the individual lens and talk about when you're working one-on-one with youth and families, that trauma-informed approach to suicide prevention and specifically intervention. And we have a paper that came out in 2021 where we worked with Dr. Jonas Sarno and Dr. David Goldston. There's a very brief intervention called Safety Acute. It can be like 60 to 90 minutes, and it really is focused on promoting strengths and giving some distress tolerance skills. For those of you familiar with DBT, from a DBT lens, it's DBT focused, where in that short period of time, it's really promoting healing and growth, safety planning, and distress tolerance in a short period of time, and has been used across different service sectors and service systems, all the way from schools to emergency departments to outpatient mobile crisis units. So we've been able to train and work alongside and adapt this intervention and learn from those that we've worked alongside for about 5 years. But I'm not going to go into each detail of this because it would take forever. But the citations at the bottom, these steps, the word step is misleading because it's really something, a framework that you use throughout, which is why it's in a circle. But what it means to adopt a trauma-informed therapeutic stance, of that whole learning growth mindset that we went over before, of getting curious about the world experiences of others, leaning in to listen and hear the story, establish and promote physical and psychological safety, that although physical safety is very important and critical, psychological safety is too. What could help promote that? We have to get curious and ask youth and communities what makes them feel safe and unsafe. Maybe coming to see me at Duke University at a hospital system and mental health system, already folks may not feel safe. So calling that into the room. Recognizing signs of traumatic stress exposure, being on the lookout for that. I love this one, mobilizing youth, family, and community strengths. Where are those connections? Where are those natural connections? And what is important? What are some strengths of the youth? Not to distract from the pain, holding both. Again, that's a DBT lens of the both and of you can have time spent on holding this pain and see if there still are joy-filled moments or still is a way to shift thinking or cognitive flexibility. Conducting the trauma-informed assessment and acute intervention, and conducting ongoing trauma-informed monitoring and care. Broadly, it would be great if we could partner across systems, like with primary care, which folks are doing really cool stuff of integrated primary care models, and you all probably are too, of how to incorporate mental health, trauma-informed approaches, and how to promote support and connection to care through those different avenues who have more touch points with youth on a broader level. So I know that's a lot, but you can go and take a look if you want to read more. When we talk about individual crisis intervention, I like to highlight that the relationship is key. Earning trust is key, and earning trust cannot be done overnight. So I'm not here saying, oh, if you have a 60-minute session for the first time, earning trust can be something that is guaranteed. It's just, what do you do to show up with authenticity, curiosity, and relationally from that human-centered lens for connection to learn more about what the youth has experienced and promoting that psychological safety. The information you need for a risk assessment, you all know this. If there's thoughts, if there's a plan to act on those thoughts, if there's lethality and intent to act on those thoughts, and do they have the access to means to do so? I know a lot of times, even when I was first learning safety planning, I had a sheet of paper and a checklist, really probably for my own anxiety of making sure I covered all of those things. But if you think broadly, these are the things that you need to assess. Now, how you get that information, I think, is even more important. I know it says equally, but I'm going to say I feel like it's more important as the information you're gathering. You have to get the information, but how you do it is critical. And how do you build relationships quickly and in an acute situation can be really tough. That having that authentic commitment to understand their story is key. Really coming in with an authenticity of wanting to learn what life has been like, what they're feeling like right now, and really learning to sit with and hold that space and share that space with the youth in a way that shows that you are able to listen to and handle the emotion and their thoughts and feelings that may be scary or out of control for them. Centering the relationship, meeting the youth where they are through, you all know this, open-ended questions, reflection, validation, and doing that in a way that is authentic, being able to lean in to just learn more, the Socratic questioning, ask questions that open the conversation. One of the things that, I'll start with, if appropriate, it's different for each person based on where they are at that moment, but even asking someone, oh gosh, what's it like to meet with someone like me in a place like this? What has your experience been? I get a lot of information there. And it opens up a conversation about either like mistrust, valid mistrust of systems, or worries of what this is going to be like. Am I going to have to lay on a couch? Are you going to send me to the hospital? And if that's on their mind, I want to know. And I know you all do too. So opening up that conversation, reflect and validate, authentically listen, reflect and listen while aiming to understand before shifting. Because an important part of safety planning is to see if they're in this spot where I think of when someone's acutely suicidal, it's almost like Dr. David Goldstein says this, it's almost like they have blinders on, that they're in so much pain that this is the only way that they see an end to that pain. And part of our assessment is to see, not to invalidate, it's to hold both. Can you validate the pain, and is there cognitive flexibility to shift? Because that's important data. If there's a cognitive flexibility to shift from that sole outcome, then some safety planning and things can happen, right? Monitor your own response and your own anxiety. Show that you can be an emotional container, convey a sense of being in control and welcoming their experience. Just showing through your body language, through your tone, through what you say and how you say it, that you can hold that space in a safe way for all emotions and experiences. I think Mr. Rogers says making the unmentionable mentionable, or something around that, which I think is really important. That's that trauma-informed stance. Shame and secrecy is one of the things that go along with traumatic experiences. So we're saying anything you say here is okay. We're here to hear it. Seeing you in control is helpful, especially during a period of acute stress where youth, families, parents feel out of control in these moments. Assessment of risk is important. I have some screening tools here for you all. There's more that exist. Some of you may use the Columbia. The ASQ is really popular too. And those things are really important to use. And the most useful information will be obtained in that collaborative, relational way. So how can you use these screening scales in a way that promotes relationship and transparency? If you are going to give it, letting folks know why you're asking those questions, where that information will go. Is it going to go in their chart? And then making sure to follow up with them on what the questions mean. So even the way that we do the screening can be trauma informed. Use your clinical judgment, consult and seek supervision. I will say I consult a lot. It helps me think things through, and I don't want to be the sole person, to be honest. Like, I want to have a group of colleagues to help me think things through. Communicate with all involved providers. If we're trying to prevent going to the hospital, and sometimes going to the hospital is necessary for safety, one of the things that I do, if it comes to that, is I try to call over to the hospital and say, if this person does have a trauma history and it's associated with the hospital, ways that they can promote psychological safety and that they're headed over there. And try to coordinate care in the most trauma-informed way in a really stressful, distressing situation of how can we at least try to collaborate and be trauma-informed. And there's lots of reason for appropriate or thorough documentation. One of them is that if they do reach a higher level or a need for a higher level of care, is having that thorough note as objective as possible is really great, because if the ED or the ER opens the chart to take a look, it's all there. And then follow your clinical gut. Don't let denial overrule clinical judgment. I like to say, if I still don't feel quite right and I'm still not feeling good about any decision I'm making, consult, and document that consultation as well. Okay. Oh no. Anna Kate, can you help me go back? Thank you. So for safety planning, again, some folks are still using suicide contracts. We like to steer clear of those. These were used a long time ago, but it's really signing a contract to say, I state my name, will not kill myself. It really is a contract of committing to not dying by suicide. There's no evidence to support their use. Could be really invalidating. I can imagine it would be really invalidating and creates that false sense of security for the provider. So steering clear of that, developing a safety plan, we really want to encourage empowerment and a return of power and control. Because if you think about suicide risk, if someone's feeling suicidal and if someone's experienced trauma, it takes away power and control. We want to be able to give that power and control back. It develops alternative behaviors and skills to use if you're feeling out of control. 2 interventions here. So the Safety Acute at the Duke UCLA Center is one of those places that does go and do national trainings on this particular trauma-informed suicide intervention. The Stanley and Brown Safety Planning Intervention is really great too, and you can get that free and online. Here's an example of what the Stanley and Brown looks like. A 6-step process where you're looking at warning signs of when youth are feeling suicidal, how do they know? The internal coping strategies, what can you think or what can you do? The social contacts that you have, family members or friends, professionals, and making the environment safe. I know I'm zooming through these, but you all will get these slides, and you can look up the Stanley and Brown or the Brown and Stanley later as well. And then also making sure you have emergency contacts. Here's 2 great examples. I know you all have heard of the 988 Crisis Lifeline, not only for youth in crisis, but also for families who are concerned about a family member or a loved one. They can call too. And it doesn't have to be suicide. It can be any mental health or substance use crisis. So 988 is one. The Trevor Project is another great one, really focusing on bettering the lives of LGBTQIA+ teens. So they have a text, a chat, and a lifeline. Same thing with 988. They have a chat on their webpage, they have text, and they have the phone number. Okay. All this is to say aftercare treatment is really important, that we know dropouts occur earlier and at more frequent rates. And one of the things that we do as a part of the ASAP Center is that after an acute intervention, we make sure to give a follow-up phone call to say, hey, we made this recommendation. How are you feeling now? How can I help you connect to care? Are there barriers? Tell me about those. Like, what are you thinking about mental health or going to outpatient care? And trying to connect to that appropriate care is really critical as a part of the intervention. Okay. Just some treatments for you all that have shown some promise in terms of ongoing and more chronic suicidal thoughts and behaviors, and then short-term, more acute interventions. I'm gonna not go into details about all of these because you'll have them, but I'll stop here. We got 3 minutes, Anna Kate. I zoomed through those last ones because I knew we were running out of time, but I wanted to give some time for like a question or a thought.
Yeah, wonderful. Dr. Tino, that was a really very helpful presentation. All of you who are interested in some of the things you saw on her slides, I will be sending those slides out to you, so do not worry. I'm going to go to the next slide with the CEU code for those of you who need it and who need to run. And while we have that slide up on the screen, I can ask you a few questions that came in. Several people were curious again about the name of that acute intervention that you had a paper published about. What was the name of that again?
It's Safety Acute. Okay. SAFETY-acute, but sometimes you'll see it called Safety A. Dr. Jonah Sarno, she's the developer of the intervention. It was formerly, this is because the name of it was changed. So it's formerly known as the Family Intervention for Suicide Prevention, or the FISP. So if you look up older articles on the of the acute intervention, it'll be referred to as FISP, but it's now known as Safety Acute.
Okay, got it. I'm sorry, a few of you had questions about the CEU code. I will be emailing you a link to a survey you can fill out about the webinar, and when you put in that code, you will automatically get your CEU certificate emailed to you. So, FYI about that. Someone else wanted to know if can somebody chime in? Does Arkansas have any kind of post-vention teams? Well, if anyone knows of that, please type that in. And then I had a few questions about what can, a therapist at the individual level, what could they actually do towards these more societal level questions and interventions, and what kind of role could they play, because they're more focused on the individual, which is really important. So is it just keeping those layers in mind when they work with the individual, or is it actually contributing in some way to that community or society level?
Yeah. I think that both and is important and also monitoring the importance of radical rest in this field as well, and your own healing, because doing this work is hard, and making sure that you take time to rest and heal is important too. So centering that, I would say at the individual level, keeping those things in mind always, and even broaching that conversation is really important, especially for folks that you're building that trust and relationship with. I also think that if there's opportunities outside of your role with the individual, if there's opportunities for advocacy or for trainings or, you know, community gatherings and community approaches to healing, I feel like that's a part to give back and be able to think and contribute from a community and societal level while also doing the individual work, because both are needed.
Mm-hmm.
But also don't burn yourself out either.
Absolutely.
Yeah.
Absolutely. Well, it's time to wrap it up. I wish we had more time for some more conversation, because this is a really helpful topic, and several people chimed in to say that they thought the presentation was very informative and helpful. So thank you so much, Dr. Tuno. I really appreciate your time with us, and thank you everybody for joining us. We will be having, you should receive an email from me here shortly with more instructions and with a copy of those slides. And we will see you in January for our next webinar. We hope you all have a wonderful holiday. And please email me if you have any questions or want some more resources. I can make sure we get those to you. So thank you, everybody. Thank you, Dr. Tuno.
Thanks,
Have a good afternoon.
Bye.